Hello, it's Renee.
Oh, hi, Renee. Thank you so much for joining us. I'm glad you were able to get in. We're about to get started next. I see some people have logged in early. They're probably trying the system out, so they get to hear all the fun part of the sausage making, I guess. Um, let's see. I need to give you access. Okay, Renee. So now you are able to move the slides. To move the
Okay.
slides, you see on the bottom of your screen, you should see a gray ribbon, and there's an arrow to the left and to the right. Do you see that?
Yep.
Okay, if you click the arrow to the right, that'll advance your slide.
Okay,
Yep,
perfect. Hey, wonderful.
easy,
Thank you.
very easy. It's easy when it works.
Yes, yes. I was very happy when they got me all connected up. So,
Great.
Lizette, I'm back on. Will you try to give
Oh,
me presenter status, and I'll see if the arrows show up on this screen. Yes, they do. Yay.
okay,
I'm
great.
going to just see if they work quick. Just going to, yep, okay.
Wonderful. So all three presenters are ready. Their slides work, and we have some early people. I see some early people on, although they might not be on the phone. And we're not getting any feedback from any of the presenters, so that's wonderful.
Yay.
Yay. So if you want to just put your phones on mute for the next 10 minutes or so, I'll get back in. I'm not going to go anywhere. I'm just going to unmute. I'll mute my phone, and then I'll start in about 10 minutes.
Great. Thanks so much, Lizette.
Thanks, everybody.
Lizette.
Thank you. Good afternoon, everybody. Welcome to this month's virtual meeting. We will be starting in about 5 minutes. Good afternoon, everybody. Welcome to this month's Public Health PBRN virtual meeting. We will be starting in just a few minutes. Good afternoon, everybody. Welcome to this month's monthly virtual meeting. We are going to take a few minutes and let some folks get ready, get signed up. I know that we are using a new system, so we might have some delays in getting all of our participants in, so we will wait just a few minutes. Thank you. Good afternoon, everyone. Welcome to this month's monthly virtual meeting. We are going to give our participants just a few more minutes to log on the line. So let's just hold off for a couple more minutes and we will begin shortly. Good afternoon, everybody. Welcome to this month's Public Health PBRN virtual meeting. Just some logistic issues before we get started. This is Lisette Fowler. Glenn is not available right now. He is in a meeting. He will try to join us hopefully near the end of the meeting, but he may not be able to, so I just wanted to let you know. If you are dialed into this call via the conference line on your telephone, please turn off your computer speakers. That will helpfully reduce the feedback. If you are on the telephone also, please mute your telephone until the Q&A period. If you do not have a mute button on your telephone, just press *6 to mute, and then when it's time for the Q&A, you can press #6 to unmute. So it looks like we have quite a few callers on the line, so we should get started. This month's presentation is hot off the press. It's a research in progress presentation by the Minnesota PBRN, an analysis of the local health department factors that accelerate population-based intervention implementation and support success by Renee Frondines, Kim Guerin, and Beth Gilstrom of the Minnesota Public Health Research to Action Network. So without further ado, I will hand the presentation over to Kim. I believe you're going to start.
Hi, I would just say welcome, everyone, and thank you for the opportunity to have the lead role in this opening part of the webinar today. We're very fortunate to have representing Minnesota. Beth and I are both from the State Department of Health, and Renee is on our PBRN steering committee representing a local health department. And she is going to kick off our presentation. And so, Renee, take us away.
All right, thank you very much. As Kim said and Lizette said, this is the Research to Action Network, or the PBRN for Minnesota, and we're looking at a summary of the data that's highlighting the factors that are impacting our population-based interventions and supports the accelerated success of those particular interventions. Just a little background information about the Research to Action Network in Minnesota. It's actually coordinated through the Minnesota Department of Health, the Office of Performance Improvement, which reports directly to the Deputy Commissioner of Health in Minnesota. And our membership is pretty varied. We have local public health representation. We also have representatives from the School of Public Health at the University of Minnesota. And then we also have representation from our Statewide Community Health Services Advisory Committee, or our SHAC committee. And just a little bit of information about SHAC. Actually, SHAC, I think, is pretty unique to Minnesota, and it really is the aspect of the state and local public health partnership in Minnesota that I personally really appreciate. It was created in Minnesota through the state statute that was developed outlining public health in Minnesota in 1976. And the committee is represented, or the representatives of the committee actually are from the community health boards, all the community health boards in Minnesota. So it plays an advisory role to the Commissioner of Health around public health issues, but it is also the avenue that we have for engaging our local elected officials around public health as they are members of the statewide Community Health Services Advisory Committee. So it's a very unique opportunity in Minnesota to have local public officials at the table with local health department directors and the Minnesota Department of Health looking at issues. As part of Minnesota's bipartisan 2008 healthcare reform law, there was $47 million that were appropriated to the Minnesota Department of Health with the goal of implementing a comprehensive evidence-based initiative that really focused in on policy, system, and environmental changes. And it was really looked at three areas. We were to increase our physical activity, to improve nutrition, and then to decrease tobacco use and exposures within our community. These were 2-year grants, and it was called SHIP, or the Statewide Health Improvement Plan or Program. And those were actually awarded to community health boards beginning on July 1st of 2009. And all 53 of our community health boards and then 9 of our 11 tribes actually received dollars. Just to give you a little bit of comparison on the $47 million, we do have, through the Minnesota Local Public Health Act, there are dollars that are awarded to the community health boards by the state, and that actually amounts to about $67 million per biennium. So it was really quite a bit of money that we received to actually do this work in our communities. SHIP really, I think, again, created for us a unique opportunity in Minnesota. This was a program that was actually statewide, so all of our public health agencies were doing work. It was very population-focused, and it was solely evidence-based strategies that we were to implement in a very short time period. And what we were trying to do by the research as part of the Research to Action Network was to take that very unique opportunity to study how the statewide example would explore relationships between an agency's capacity and then its ability to actually implement strategies that were evidence-based. And along with that, what kind of factors may have prevented agencies from being able to roll out a new evidence-based chronic disease program in a very, very short time frame. So these are just two of the many, many, many initiatives that were implemented by SHIP across Minnesota. The first one is the farm to school sites, and then the second is the safe routes to school. And you can see by looking at both of these initiatives that there was a large percent of Minnesota that was actually served, and it's pretty much statewide that we were seeing these initiatives. But again, these are just two of the other examples, many examples that were there. So some of the other things that we saw a lot of is in our metro counties, for example, we had over 72,000 students who, through the work of the community and public health, there was a change, a major change actually, to the food service system, where they were increasing fruits and vegetables being sold to students. And what we saw was an estimated increase by about 25%. And then also with those changes in increasing the breakfast and lunch participation as high as 30%. There were 4 schools in one of our rural counties with about 2,000 students. where they actually changed how the students were doing physical activity within the school setting. And we also looked at daycare centers. We had 902 daycare centers that now have integrated movement into the learning, and we're reaching almost 22,000 children in that particular program. So a lot of work was done and continues to be done in Minnesota around this particular area. So if you look at Minnesota, there are 87 counties. We have 53 community health boards that govern 74 of our local health departments. And the community health boards actually are represented by a pretty large range of structures. We have some that are multi-county, and you can see like in the northeast, northwest, southwest, where we have more than one county which are together as a community health board. We also have others that are single. So for example, in the middle of the state, you'll see Stearns County. We are a single community health board. And then in some few instances in the metro area, we have cities. So we do have one county community health board that is functioning as a single health department in the Southwest. So they actually are a community health board, but they also are one local public health agency as well. We have other multi-county community health boards that also have different structures where they share services and resources. Some that we have, particularly in the Northwest, where they're contracting for the services in hospitals. So lots of different structures that are out there. The data were actually compiled from a variety of sources, many of which were reported at different levels of the reporting entities. So there were community health boards, but local health departments as well, and then county and city. So the final set, the data set, actually included 91 cities and counties that were considered reporting entities. And for the purposes of of the regression, some of the city level data was not available for all the variables that we looked at. So the final sample size was 87 instead of the 91. And I will turn it over to, I'm not sure if it's Beth or Kim.
This is Beth. Thanks, Renee. Hopefully all of you, as you heard Renee talk about the complexity of our system, can realize it was kind of a challenge to compile that data across, and we'll talk about that a little bit more later. What I'm going to start off with, though, is just giving you the basic study design and data elements and talk about the quantitative component, and then Kim is going to talk in more depth about the qualitative interviews. So we were really interested in looking at this major initiative that rolled out 2009 to 2011 statewide, and wanted to see if there might be some factors related to health department capacity or organizational structure, QI culture, that might be associated then with SHIP grantee performance. But we also realized that looking at it strictly from a quantitative perspective, that we might really lose some nuance or be able to learn more about what really facilitated this rapid rollout of a comprehensive intervention strategy, and also what might have been a barrier. I think we have noted in Minnesota, and I'm thinking this has probably been an experience for other states as well, that sometimes, money hits and there's a big initiative and you have to be able to turn it around quickly and roll it out at the local level. And we're trying to get a sense for, what types of factors may help in that situation and what might be a barrier. So I just wanted to give you a snapshot of some of the quantitative data elements, and mainly to show you the many different data sources that we were working with. Renee mentioned this, and we have some health departments that report in at the CHB level, some report as a health department, some of our data was county level, some are multi-county CHBs who report together, some are multi-county CHBs who report individually on different things. It really was a challenge to be able to create a single data set with one denominator across all of this. And I would spend many minutes, Kim and I would spend a lot of time talking about our reporting entities and how to make all of this work. I did want to talk in a little bit more depth about a couple of the variables and how we develop those. The first being our main outcome variable of interest, which is that SHIP ranking. So an evaluation team within MDH reviewed all of the annual and interim and final reports that SHIP grantees submitted to MDH, as well as how they were adhering to grant requirements, their use of technical assistance, and really reviewed them on topics related to their community leadership teams, their coverage of at-risk or high-risk populations, how they were communicating, their communications efforts, but also how far did they get. You know, they had a menu of interventions that they could choose from, and you know, this evaluation team took into account then what level of implementation were they able to achieve for each intervention, and then also an evaluation component. Now, they were scored out of a total of 50 possible points, but then they also went a step further from that scoring and looked at the grant requirements and technical assistance to come up with basically a final ranking that would either be exceeding expectations, meeting expectations, or approaching expectations. So 3 levels of performance by our grantees. And then the other variable that isn't probably as straightforward is this idea of a QI maturity score. We're really interested in Minnesota about organizational QI, kind of that idea of cultural QI maturity. And so we have been working with the University of Southern Maine and then also with our representation on the Research to Action Network to have both that academic perspective, Bill Riley at the U has been really instrumental in this, but also the practice-based perspective of our local public health representatives to take the QI maturity tool that has been used in the MLC surveys for 2009, 2010, and 2011, and really try to whittle that down to 10 questions. We have other uses for that within Minnesota where we are hoping to track the organizational culture, kind of where our system is in terms of QI maturity over time, but then also individual health departments as well as MDH itself is using it to track organizational culture. And we can't do a 65 or 70 question survey every year with our local public health agencies or even within MDH. And so this is something we've been working on to identify these 10 questions, started with those that had the highest factor loading scores in studies at the University of Southern Maine. We flew Brenda Jolie out to Minnesota last year to consult with us and really work to find which questions were both relevant, the most relevant to QI maturity, but also that had an action component to them. And so I just wanted to briefly show you the 10 questions, or a little synopsis of the 10 questions that fall within the 3 major domains of organizational culture, capacity, competency, and alignment and spread that go into calculating this score. And then what we did is, so all of our entities then had this QI score, and it's fine when you're doing a median for the system overall and trying to track your change over time, but we did realize that we might have some misclassification at both ends. So kind of the idea that as an organization gets further along in their QI culture, that they might self-assess themselves more stringently than when they don't know as much about it. And when we took a look at where some of our health departments or CHPs were rating themselves, you know, there were some instances where we said, well, you know, my goodness, you know, this county health department is further along than anybody else in the state, yet they're really hard on themselves in this self-report. Similarly, we had some at the other end where we knew anecdotally that they really were not doing much with respect to quality improvement yet in their organization, but yet had really rated themselves very high. So it's kind of that maybe what you don't know may influence your rating. And so we worked with the QI consultants within our office who work with local public health, as well as our regional nurse consultants, to see if they agreed with the score, had them review all of the scores, and then we assigned our reporting entities to either be in a high, medium, or low level of QI maturity. And so you see about 16 of our entities we reassigned based on that expert input. And then it also, though, allowed us, we didn't, you know, try to generate an actual raw score for them, but we had about an 80% response rate statewide on the full QI maturity tool, which is where we were pulling this. And so we did ask our experts then to assign those 20% who had not responded to the survey to a category just based on their knowledge of their level of QI work. And to do that, we really went back to the QI roadmap to help try and correlate what does low, medium, and high mean to us within our system. So really that low being, either the no lot knowledge or just starting to get involved, medium, doing some ad hoc QI within the organization, getting their feet wet, the high people really moving towards this idea of a QI culture. So just a snapshot of some descriptive statistics. We pulled 2 questions related to accreditation, and you'll see that, almost 50% of our reporting entities felt that they could actually obtain national voluntary accreditation. Only about a third or less than a third have actually begun preparing back when they took this. In terms of our QI maturity score, really the bulk of our system is either at that medium or low level. Almost 20% would we consider high, but really our system is probably kind of right in the middle and really focused more on that ad hoc QI. I know you've heard from Kim present on our authority of top officials. We pulled that data into this study, looked at governance structure. We also looked at organizational structure, multi-county versus single county. And then that final SHIP ranking, you'll see the bulk were in that meets expectations, but we did have almost 30% be classified as exceeding expectations on the SHIP initiative. So this is just very preliminary, and we're still looking at how we can best model our QI maturity score and some of other factors. But we were really surprised because a lot of the variables that we thought would be in this model, like is it a standalone health department or is it within a human services agency, or does governance matter, whether it's a human services board or just a straight community health board, authority, all of these things that we thought would show up in the regression really were not statistically significant. The QI maturity was highly statistically significant, but you'll notice the precision isn't as great as we would like. We've consulted with another University of Minnesota professor to help us with this, and he's just kind of reached the point where he said, well, you're just going to need more data to be able to improve the precision on that confidence interval. The other variable in the model is expenditures in 2010. So that would be the full calendar year that our local health departments were getting SHIP, and it's expenditures out of the area of responsibility. We track expenditures over these 6 areas of responsibility, but the one that SHIP would have really fallen under did appear, it's borderline significant, that increased expenditure did seem to have an influence, at least a positive relationship with performance on the intervention. So when I look at the lessons learned, I think that, this surprise, we feel like there's more to measuring the nuance of organizational structure and governance, and that we didn't capture that with our dichotomous representation of it. And we're starting to really think about how can we better measure this for quantitative purposes. Is there something related to leadership, but not, it's not as easy as looking strictly at authorities, but there's something more complex there, and we haven't figured out yet exactly how to model it, but it's something we think a lot about and are hoping to go down the path of getting maybe a better variable for this particular type of analysis. It was definitely possible to pull together the data from multiple sources, but it was really difficult, and we had to make some assumptions when the reporting entities differed between the data sources. And we are hoping to be moving in a direction of more consistent reporting in Minnesota, so moving in the direction of community health board reporting and trying to get that more consistent over our different data sources. But then that will introduce another issue in that then our sample size will go down. We have fewer community health boards as compared to health departments or counties. And so we're beginning to realize that if we want to do more complex analysis and be able to look at more factors, that really moving towards some perhaps more multi-PBRN studies, may be really critical for us to be able to improve the precision of our results and really be able to draw solid conclusions from the work. So I think it's really raised some interesting possibilities, but also shown us kind of where the limitations are and what we'd like to improve upon. So with that, I'm going to segue to Kim Guerin, who will be talking a bit about the qualitative interviews.
So we had the good fortune of complementing the quantitative analysis with some qualitative interviews. We we invited 15 of the SHIP grantees to participate in telephone interviews, and that represented about half of all of the SHIP grantees in the state. We identified grantees who represented each of the levels of performance, so exceeded, met, or approached expectations. And we were also looking for sort of a balance of representation, multi, single county, standalone versus combined in a broader structure, different areas of the state. And we wanted to conduct these interviews over the summer, and we pulled that off in July and August. We developed an interview tool in collaboration with the steering committee of our Research to Action Network, so that included both researchers and practitioners. We pilot tested the tool with some staff at the State Health Department who used to work at the local level and were familiar with SHIP. Beth and I both conducted the interviews and recorded them, and then had them transcribed by an external vendor. And we used a coding approach that was originally developed by Christopher Hahn. So all of the potential key informants that we approached agreed to talk with us, so we had 100% response. The interviews lasted, on average, just over a half an hour, but some took up the full hour. And you can see from the characteristics listed on the table that we were successful in kind of getting a broad mix of people to talk with us. We talked in some cases with the director of the organization, and in some cases a designee, the SHIP coordinator. So we haven't finished all of our coding, but we're starting to identify some preliminary themes, and we just kind of wanted to share some of those with you now on the next couple of slides. There were, people had a lot to say about staffing, and it seems pretty crucial to hire a SHIP coordinator who was really dedicated to this work and didn't have to divvy up attention with other programs or services. Very typically, grantees had to hire new staff because of the size of this initiative, and it seemed very helpful to have a mix of current staff and new staff with new expertise and experiences. We had health departments hiring for the first time, people who really had experience in the schools, business backgrounds, dietitians, planners. So this combination of new expertise and solid familiarity with public health seemed important. Another key theme is related to leadership and community health board support. Several of our grantees talked about how important it was to have a strong director, or to be a strong director who could, quote unquote, run interference with the board while giving a lot of freedom for SHIP staff to act. There was a lot of variation in the amount of SHIP support. I think by and large, as a state, people have been surprised at how readily and quickly some community health boards and some elected officials were able to come on to the project. But it was very nuanced. You could have on one board some who were very supportive and some less so. And just to give you an example, we had one informant talk about how she just really wanted the elected officials on her board to be public health advocates. And now I just want them to let me do my job. It was kind of like engagement was a double-edged sword, because they really started getting too engaged at a level where I think they micromanaged. So this relationship with the board is a really complicated one, and we heard in some cases where it worked very well and in other areas where there was a lot of complication. Kind of related to that, we had strong directors who were sometimes stymied in their work because of the structure that they were in. And this kind of gets at the interrelationship between leadership and CHB support, as well as organizational and community characteristics. So for example, in a broader structure where a director might not have authority over the whole agency, some directors found it challenging to bring up population system, policy systems and environmental change orientation to, for example, a human services structure. It was sometimes just a real foreign language to talk about TSE in that environment. And in that environment and other environments, it was sometimes hard for the full organization to really embrace doing something new. A real new part of the SHIP project for many of the grantees was really meaningfully engaging the community and having the community sort of driving what happened locally. So for example, some of the grantees wanted to have members of the community leadership team on grant review committees to decide who would get local funding. And one of the director, I have an extended quote from one director that I won't relay all with you, but she talked about what a stumbling block it was, on the one hand, to be working within her community and moving and engaging them, and to come back into an organization that really didn't understand policy systems and environmental change, and the difficulty in going back and forth with the community and sending mixed messages to the community about what the project was all about, to the point where some key leaders in the community going forward said that they really wanted to be less engaged as a result. So an example of how factors within the organization can stymie even very strong leaders. And that gets at the idea of really trying something new as well. A flip side example is we had one grantee try to do something very different, hired a grants writer with their SHIP funds, who subsequently brought in $500,000 in trail construction resources. So some organizations found it easier to really embrace the opportunities brought by SHIP, and others found it more difficult. Financing, interestingly, was a bit of a blessing and a curse. Obviously, it was great to get support for SHIP at this level statewide. At the same time, this program rolled out during the recession, and so there was a tremendous amount of scrutiny. And so one of the things, unfortunately, that happened is a grantee might actually lose FTE funded on local tax dollars because elected officials saw this new infusion of dollars and saw it as potentially replacing staff that they already had. And then when SHIP funding was scaled back after the first biennium of the project, those staff, those FTE were not replaced. So it was kind of hard to see things like that happen, and yet they did. So a couple of other themes to quickly hit on. There seemed to be a big advantage to the multi-CHB approach. SHIP incentivized some health departments who hadn't previously worked together to work together, or some that hadn't worked together to take that collaboration to a new level. And we heard repeatedly about the benefit of sort of just regional support, formally and informally, sharing of ideas, being able to be a sounding board for each other, but also more actively sharing training and resources across borders. Admittedly, geographic distance was at times a barrier, but we heard really loud and clear about advantages to this regional approach. In terms of translation and sustainability, the program was scaled back significantly after the first biennium, so we were very interested to know about how even after just 2 years there might be evidence of sustainability and translation that our key informants would point to. And many talked about just how the increased knowledge and buy-in around a population-based approach was a huge advantage. There's across-the-board disappointment that the program was scaled back, but there's this sense that the system is really poised for more of this work. There were multiple examples of how health departments had worked together to secure additional funding, writing joint grants, aside from the next iteration of SHIP, so for federal funding, for example. There's also multiple examples of how local tax dollars went into supporting some of the SHIP activities that had been initiated and would otherwise have been scaled back. There was some interesting comments multiple times about the difference between having hired staff versus contract employees. And those who had hired staff seemed to, in retrospect especially, really favor that because they felt like it left more of the capacity within their department than those who had contracted for some of the SHIP work. So in terms of the QI collaborative, there was a component of SHIP that encouraged grantees to participate in a statewide collaborative to embed quality improvement in the broader SHIP initiative. And I confess I was there. At the state level, we thought this was a huge opportunity to wed two big, new, important things, and we heard almost to a person that it was a mistake, that there's this agreement that QI is important and valuable, but at the time that we rolled QI into SHIP and the way that we rolled it out, it was just too much. It was viewed as another thing to do and really poorly timed. And so that has been sort of an immediate, very helpful finding to us as we think about folding QI into other statewide initiatives. We didn't ask a lot about, we really didn't ask at all directly about MDH and the role of MDH in SHIP, but many references to MDH came up over the course of the interviews. And so it seems as though, for the most part, people had positive things to say, but it was clear people were recognizing that then the MDH was learning alongside the grantees, and we were stretched a little bit thin. Scanning my notes here, I think I've hit the highlights, so I'm going to turn it back over to Beth.
It looks like we were both advancing the slide at the same time, Kim.
Sorry, yeah, that happened earlier.
Sorry about that. Oh, okay. Hold on. We'll go. I'm going to just advance one.
Okay, I'm not touching it.
Okay, perfect. So overall, we did feel that a culture of quality appeared to be associated with success on implementing SHIP, but we aren't really sure if that quality culture is really just a marker of overall capacity or if whether it has its own unique contribution. Those organizations that really use their funding to hire a designated SHIP staff, as well as those that gave that staff freedom to act, they could make decisions, they could spend the money, they were really more effective in implementing the intervention. The role of leadership and that relationship to the CHP was really important, probably more so than strictly looking just at what is the organizational structure or governance structure. And then really having SHIP statewide was crucial. It allowed for this regional sharing of ideas and resources that went even beyond their own grantee partnerships, and those grantees that really talked about, you know, I could call across to this other grantee and bounce an idea off of them, or, you know, that they kind of formed their own almost support network that really seemed to help them as they were wading into this new world of policy system and environmental change. We had touched on the limitations and challenges. I wanted to just mention that the qualitative interviews, we were really asking our respondents to think back on their experiences with SHIP, and many of them also, you know, they obviously knew what their current funding status was. Some of them had lost funding in this second biennium, and, you know, it's possible that the success of their project or whether they had been funded again may have influenced some of their recall, but it really did seem that people were excited to provide answers and to talk with us and give us insights, and I think they really were trying to think back to those 2 years and characterize that implementation as accurately as possible. So with that, I'm going to turn it over then to Renee to close and talk a little bit about the implications of this for our system.
Okay. As a local public health director, I think the study has really, from my perspective anyway, has some great practical-based implication. First of all, I think we found that there was great success in working together around SHIP. The fact that it was statewide created what I'm calling an artificial, and I'm no pun intended here, we're all in the same boat mentality. And I think that really did foster some great cross-jurisdictional collaboration and coordination among public health. And we're actually seeing that continue to spill over into what I'm calling SHIP version 2, which is continuing, as well as in other areas, in some of our planning, certainly for our region, some of our data collection, those kinds of things. So it's continuing, I think, to move forward across the state. And I think if you look at our current SHIP activities, there really isn't anybody that's doing it what I'm calling solo anymore, maybe just a couple. There's been a lot more collaboration that's actually come out of that. So, and again, I think the fact that it's a huge population-focused, statewide common goal really highlighted the fact that the artificial boundaries that we have in public health don't always fit when we're working with all these other partners within the public health system, and which again I think highlights the need for us in public health to continue to develop and nurture those relationships that we have across jurisdictions. Our next steps, in other words, where are we going to go from here? Well, I think we want to make sure that this information is actually used as Minnesota begins to craft a future SHIP activities, as well as any other interventions that we're going to be implementing, particularly those that are statewide. So that means that it's critical that our policymakers, our staff at the local health department level and the Minnesota Department of Health need to get this information so that as we look at future work and future policy, this data is actually driving those decisions. I think we also want to focus or further explore, based on some feedback that we had gotten from our Research to Action Network Steering Committee, and then also we did at our local or at our statewide Community Health Services conference that we had earlier this fall, we did sponsor a session where we asked them to provide us with some feedback on where we should focus as well. And so based on that, we're really looking at how governance and how structure actually will impact our work at the local level around these particular items. And then lastly, I think we want to make sure that we are continuing to explore the use of the QI maturity score and how quality improvement maturity can actually impact success with us implementing changes, and then also provide us, I think, with more tangible support at the local level for growing quality improvement within our own agencies. This last slide is just an acknowledgement of all of the different organizations that have actually helped us or supported us in doing the work that we've been doing, and we'd really like to thank them for that as well. And then here's our contact information.
Thank you very much, Renee, Kim, and Beth. You guys did a great job of really coordinating well with each other and doing a great presentation on this very useful topic. I think we're going to open it up now to Q&A. If you have muted your phone, you can unmute by pressing #6. If I cannot hear you, what you can do is you can go up to the icon at the top of your ribbon bar there, a little icon of a person raising their hand, and you can raise your hand and or put your question into the chat box, and I will be happy to ask that for you. Do we have any questions? Okay.
Hi, this is Scott Frank from Ohio. One of the differences in what's happening in Ohio with what you've presented in Minnesota, or let me check it out to see whether it's a difference. As a result of the public health accreditation process that's coming up, many, if not most, of the Ohio health departments are doing community health improvement plans in addition to the state health improvement plan, and there hasn't been any specific effort to coordinate between the state health improvement plan and the community health improvement plans. Do your local health departments do their own community health improvement plans in addition to the state plan, or is it just the state plan that you're working with?
So just to clarify, this, looking at SHIP, our acronym for SHIP is different than like our statewide health improvement plan here in Minnesota. It's a poorly acronymed, we will not say, but it was really a really specific intervention that was funded through the legislature. That said, yes, our CHBs, our community health boards, do community health improvement planning, and that has been a requirement in Minnesota actually for a while, that they do that as part of, they do a community health assessment and a community health improvement plan, and then do try to tie that, or at least look at what the state has done as well. But yeah, that's a little bit of an unfortunate acronym issue here in Minnesota, if that was confusing.
Beth, if I can speak just as a local provider, related to the community health improvement plan, yes, it is done individually at the local level, but we do work really quite closely in collaboration with the Minnesota Department of Health around obviously the data and the review of the data, but also particularly, I think this year, look towards the Minnesota Department of Health to sort of set up the structure of what our plans would actually look like futuristically. So I think, we have the freedom to do whatever it is that we want to do as long as we're doing the assessment and putting the plan together. But I think historically have really relied on the Minnesota Department of Health to sort of put some structure around that, and then have used that as we've completed our plans. And that has been part of the requirement in public health since 1976, when our Local Public Health Act was initiated. So, and I think as we looked at SHIP, I think similarly, we looked for that technical assistance from the Minnesota Department of Health in SHIP. The intervention that we were talking about, I would say, was similar to what we would rely on as far as technical assistance around the Community Health Improvement Plan. So that partnership, I think, has sort of established the need at the local level for that technical assistance that the Minnesota Department of Health has typically provided for us.
This is Dave. Sorry.
Go ahead.
This is Dave Palm from Nebraska, and I was just wondering. You did a scaled down QI maturity index, and did you feel that reflected the QI maturity in your health departments. And my second question is, even though I know Minnesota is ahead of most states, certainly where we are in Nebraska with QI, is it still too early to detect the impact of QI on other factors?
So for your first question, we think it, from just kind of a face validity standpoint, when we generate a median QI score for our system, or when we look at what the score generated for our individual health departments, or even when we look at the MDH score, which, to be honest, is actually lower than that of our system, which we actually would expect to see. We know that we have local agencies that are further ahead of us in QI. So from a face validity standpoint, we think it may be capturing what we're looking for. But we really want to continue to stay in touch with the University of Southern Maine as they continue to conduct diagnostics on the full data set, because they just have so many more, they just have a much bigger sample size than we would in multiple years of data to be able to really be pulling this out. So we're trying to build on their work and really also trying to take a little bit more of a practical approach than a purely academic look at what would go into the score. We wanted to have some items that were things that you could actually maybe measure some change over time. So we've really only been using it for about the last year, and we have 2 data points in time for MDH where they've taken it twice over, with about a little over a year in between the administrations. And then we're gearing up to collect it from our local system again in February and March, because we're incorporating it into our annual reporting system for local public health. We'll have those 10 questions. So right now it's a little bit developmental. We're happy with what we're seeing, but it's still so early. We're not entirely sure that this is the exact right, able to capture every nuance of organizational culture. But we just knew it was not going to fly to do the full tool every year, either within our health department or with our locals.
Yeah, I think that's, we did a pretty lengthy survey about 1.5 years ago with our local health departments, but we're not going to be able to do that, consistently over time and get a good response. So I think you're modeling this scaled down tool is really important and should help the rest of us as well.
Well, and if I can just interject too, I think the fact that we've incorporated those into our annual reporting requirements to the Minnesota Department of Health, those 10 questions, we will be gathering, we're required to report that information. We report to the health department, and that's just been incorporated into our regular reporting. So we'll be able to collect that data and not, be required to do another survey at the local level. So I think that'll be really good.
Yeah, that should be very helpful. And do you think it's still too early to really detect the impact of QI on various factors?
I think, our median for our system is really right in that ad hoc QI area, if you really look at the system overall. But we have a fair level of variation, or like a range of scores by health department, and we thought, let's see if there appears to be an association. Let's see if there appears to be any kind of relationship. Now, what's hard to tease out is, as we're using it, and as I think about it, is, when you think about this QI culture, is that its own entity, or does that reflect something about just the overall capacity of this health department? Do we have health departments that innately have, certain capacity that then, because of that, they have been able to take their QI further along, or has QI pulled them up? It's really difficult to tease all of that out, and we were just curious to see if there was really any association at all, whether we can make any kind of association with it. But it's definitely, a preliminary look at whether or not we think this organizational QI culture may have set a stage or been important for this rollout of this intervention.
Yeah, I know. It's a very interesting question, and I tend to think you're really going down the right track. So it'll be interesting to see how things play out over the course of the next year or two.
Yeah, absolutely.
Thank you. That's a very lively discussion. Any other questions? Okay, then I am going to turn things over to our Deputy Director, Anna Hoover. She is going to go over the rest of our agenda for today. We have various items to discuss, so Anna, it's all yours.
Thanks, Lizette. I appreciate that very much. We're going to just cover a couple of things and play catch-up on the IMPROVE study. We have selected the measures. The groups involved in the IMPROVE study have selected the measures. The final emails will be going out to those folks, delineating those in the process by the end of this week from Glenn. In the next few weeks, we're going to start talking some about generating the guidelines for collecting the data related to those measures. So we'll be having those conversations, and we'll keep you posted on how that all goes. We also want to mention that Robert Wood Johnson Foundation has been doing a policymaker outreach series. It's a webinar series. Their next edition is coming up next month, leveraging the media to gain policymaker support. We would definitely encourage everyone who's available to take part in that. Obviously, dissemination is key to all of our research efforts, and policymakers are an important constituency for the kinds of research that we're doing, so we want to make sure that we're all kept up to date on what the latest strategies are and why it's so important. I'd also like to direct everyone's attention to a couple of reports that came out this week. One is the Institute of Medicine's report on an integrated framework for assessing the value of community-based prevention. I've had a chance to read through most of this, and it's really quite good. The report was backed by Robert Wood Johnson Foundation, the California Endowment, de Beaumont, and Kellogg. So all of the big guns were at the table in recognizing the need for evaluating the existing frameworks for assessing community-based prevention and starting to carve a path forward. So it's really excellent. It's online. You can Google it, or it's linked from our agenda. Unfortunately, the links don't seem to be working on our slides today. So if you go back to the agenda, you can link from that, or if you can't find it, shoot me an email and I'll get that to you as soon as possible. Along with that IOM report this week, the National Academy of Sciences also issued a report on using science as evidence in public policy. I think we're detecting a theme here. Robert Wood Johnson on the policymaker outreach series, and now the NAS report on science as evidence for public policy. They talk about why scientific evidence is important to policymaking, look at the gaps in understanding for how evidence has supported policymaking previously, also how we can move forward on doing a better job of making sure that policy decisions are informed by the evidence. So all of that is online and linkable from your agendas. In terms of research funding updates, we have a couple of pieces from PCORI. One is a funding update and one is a request for information. They are both related to research networks. Glancing here at the RFP, they're looking to create networks that are conducive to conducting patient-centered outcomes research. And they're looking primarily, you'll see as you look at it through both the RFP and the RFI, what they're looking at primarily is two kinds of networks that they have delineated. One is a data sharing network, and the other is a patient-driven research network. So I think we all want to look at that and try to identify where we fit in the puzzle, see if we can come up with some ways to make sure that we're at the table for this work, because it's very important. We obviously have research networks. We have an understanding of how to do this kind of collaborative work, so we definitely have an obligation to make sure that we're part of that PCORI picture. Also, we have out right now the PHSSR Junior Investigators.
RFP, and I'm going to turn it over to my friend Jay Swacker from the PHSSR National Coordinating Center. Jay, are you there?
Yes, I am here. Thank you very much, Ann. We are excited to have, this is the sixth round of funding for these awards. They are $10,000 fixed price awards. The applications are pretty brief. They're only 2 pages in length in terms of proposal narratives. One thing, now that we are working with Glenn and the folks at the PBRNs, we would like to encourage applicants to seek out PHSR expert mentors that are working with the PBRN, so just so that you are aware in case you get an email from or a phone call from some bright-eyed, bushy-tailed PhD students or postdocs, you will not be caught off guard. The applications are due at 3 o'clock Eastern on December 5th, and if you are aware of any junior investigators, young folks that you think would be interested that are at academic institutions affiliated with your PBRN, please tell them to come to our website, publichealthsystems.org, for more information, or they can email or call me. And I don't know if I'll be happy to answer them right now.
Does anyone have any questions for Jay? You can either unmute your phone, or you can raise your hand, or you can type it into the chat box. All right. If any questions arise and you don't know how to get hold of Jay, let us know and we'll help you make that connection. Thanks so much, Jay. And the last research funding update that we really want to hit on is the NNPHI call for proposals and PHSSR. There are 2 kinds of award mechanisms they have right now. Short-term studies up to $200,000 each for a maximum of 24 months. And these can be qualitative or quantitative. They ask that they focus on research to understand how the public health system influences the implementation of evidence-based public health strategies and the implementation of public health primary care integration strategies. So going back to that IOM report this spring that talked about the need to better integrate public health and primary care. So if you're working on any of those areas, you definitely want to look at this NNPHI opportunity. There's also up to $450,000 3-year funding available for complex and comprehensive studies looking at primarily multi-state time series analyses or really in-depth studies that are focusing on comparative effectiveness. So if that's something that interests you, you want to look at the NNPHI studies. And again, these are available online. They're linkable from the agenda you received for this meeting. Finally, in getting into a little bit of housekeeping, most of you have already responded to the quarterly check-in calls that we've instituted. Thank you so much for your cooperation on that. We'll probably start another round in January, so those of you who have already participated may be getting calls in about 2 months. If you haven't responded yet to our research assistants who have been trying to set these up, please do so. If we have funding opportunities come forward that are CFPs and we need to get in touch with your networks to make sure that you have all of the most current information to apply, we need to make sure that we have the best information to contact you by. Also, these quarterly check-in calls really provide an opportunity for us to get to know what kinds of technical assistance you need. It's an opportunity for us to get feedback on how good or bad a job we're doing in certain areas and learn and improve. So we want to make sure that we're serving you the best way we can, and that's a big piece of these quarterly check-in calls. So please, if you haven't already talked to our research assistants, give Rachel a call. She will set something up for you at your convenience, and we're going to try to finish these in the next couple of weeks so you don't have to hear us talking about them anymore, at least for a month and a half. You'll get a holiday break. Lizette, I think we can go to the next slide.
Can you talk about the Keeneland abstracts?
I was going to do that under dissemination.
Okay, great. All right.
And we're at dissemination now, so we can go. We had a meeting this morning with Kara and Vicki. I think Vicki's been on the call, so hi, Vicki. And the abstract selection is online now for Keeneland Conference 2013. That's coming up in April. We are using a new system to solicit your abstracts this year. So I would need to make sure that everyone understands that with your submission, if you are submitting a panel, you need to submit an individual abstract for each speaker's presentation. And note somewhere in the narrative that you are part of a panel listing the other panelists. This will make sure that we don't end up with a situation where we have someone who thinks that they've signed up for a panel and they get there and instead of having 4 slots, there's 1. So again, as you fill out the abstract, it is online, it is on the PHSSR website, linkable from the PHSSR website. Make sure that if you are submitting a panel, that you submit an abstract for each presenter, and that you tell within those abstracts that it is a panel and list the other presenters. Vicki, is there anything that you need to add to that?
No, I don't think so, Anna. Sounds like you covered it. Thank you.
Thank you. Moving along, we want to thank all of the PBRNs for their presentations at APHA. We had about 25 presentations. We got to see and visit with a lot of you. It was a real pleasure. It always is, and we're looking forward to seeing you again at Keeneland. So let's start planning for that. During APHA, the Journal of Public Health Management and Practice put out its special issue on PBRNs and PHSSR. That is now available online. It is linkable from the agenda from yesterday. There is a Frontiers special issue on PBRN research and production. We expect that to be coming out shortly. And we have an AJPM PBRN theme issue coming up around January, early February. So those are all things that are on the horizon. We encourage you to continue submitting to Frontiers. If you have an idea for a React podcast, please send me an email. We'll make sure to get that scheduled. I'll probably be in touch with a few of you soon. We've been going through the quarterly check-in calls to identify people who have research that's ready to be released in that channel, so we're starting to work on that. But again, if you have anything for React, do send me an email and do keep sending in those Frontiers submissions. We are looking at some different ways of making sure that Frontiers is getting out as quickly as possible, so we'll be keeping you updated on those. In terms of upcoming meetings, well, the first item here obviously was a webinar from yesterday, but we wanted to add it here because Academy Health has been having a webinar series largely focused on translation and dissemination, and they are archiving those. The one from yesterday is not online yet. It takes them a week or 2 to get them up, but they are starting to archive these translation dissemination webinars online. We want to make sure that they're on your radar. They've been posted about on our LinkedIn group, so please, by all means, if you're available during some of those webinars, please register for them. They're really helpful. They'll be really beneficial in the long run as we're starting to push our research out there. Then coming up on November 29th, this is hot off the press. We just set the date on Monday. Glenn is going to lead a quarterly training session on conducting comparative effectiveness research and patient-centered outcomes research studies. So in light of the PCORI funding announcement and RFI we talked about earlier, this is going to be a really good virtual training, and he's going to talk about everything from the design to the analysis to where to obtain funding. So we definitely want to put that on everyone's radars, make sure it ends up on everyone's calendars for November the 29th. And then December 20th is our next monthly virtual meeting, and that's going to be Research in Progress by the Massachusetts PBRN, and we're all looking forward to that. Minnesota did a great job today. Every month I'm learning so much from all of you, and it's really an exciting time to be involved in the field. Lizette, is that most of the items that I'm supposed to cover before we go to Grants Administration Corner?
Yep, I believe that's it.
All right, well, I'm going to hand it over to Lizette, and she's going to get down in the nitty-gritty now. Here she is.
Thank you, Anna.
I'm sorry.
Sorry, did someone have a question?
Yeah, this is Thomas in Jacksonville. Accessing the November 29th training, will that can be available to all of our PBRN members as well?
Yes, Tom. And we'll be sending out an email with all of the scheduling information on that as we get a little bit closer to time, but that will be open.
Okay, thank you.
And if you're not available on that day, we do archive those on the website as well. So thank you.
I thought that for this month's Grant Administration Corner, I would do a little review of what an NPO is and our function as the National Coordinating Center. The Public Health PBRN National Coordinating Center is a national program office of the Robert Wood Johnson Foundation. The foundation awards most of its grants through their national program offices. A national program office is a cluster of grantees and other interested parties who work together to create impact in a specific program area. So the main functions of an NPO, and therefore of the Public Health PBRN National Coordinating Center, are grant making. We facilitate the review of proposals to become project sites, monitoring. We review grantee performance and financial reports, and we are in charge of ensuring submission of grantee reports to the foundation. This is why it's very important to make sure that the PBRN National Coordinating Center is copied on all report submissions to the foundation. Technical assistance. We provide a range of assistance to project sites and help you implement and sustain your projects. Communications. We focus national attention on the public health practice-based research network model, and we facilitate a steady flow of communication among sites, the foundation, and any relevant mass and professional media. Consultations. We advise the foundation on trends and developments in our practice area. And program leadership. We collaborate with the foundation on the program's development and work with you, the project sites, to enhance this implementation. As I mentioned earlier, a major part of our program management activities involves monitoring grant budgets and reporting requirements. To this end, it's very important that all questions or issues regarding grant budgeting, reporting, and administration be directed to us here at the Public Health PBRN National Coordinating Center. Specifically, anytime, as you know, that there are budget revisions, those have to be reviewed by the center before they can even be considered by the foundation. It's also important that any changes in individuals named in your original proposal be communicated to us as soon as possible so that we can ensure that the foundation has the most current contact information. This is particularly important during reporting, so if there's a change in the person in charge of any financial reporting, we can ensure that the new person is aware of the foundation's requirements and procedures and that your reports actually go in and appropriately. We especially appreciate any questions regarding your products, as we are just as excited as you are to highlight and promote your great work. And I know that sometimes there are gray areas as to what constitutes a product, and we are really happy to take those questions. We may not always have the answers right away, but we will work with the foundation to get an answer to you as soon as possible regarding any products or any other questions. Lastly, I just want to remind everyone, of course, to route all your grant reports and products to the Coordinating Center and the Foundation, both. And as we always finish up our sessions, we have all of the links that you can refer to regarding guidelines for annual, final, narrative reports in your bibliography, guidelines for financial reports, and guidelines for electronic submission standards. So with that, I'll turn it over back to Anna. I think we will end our session. Anna, did you want to say goodbye?
I just want to open the floor one last time if anyone has any questions or concerns about anything we've covered. And I'd like to reiterate quickly what Lizette said about the importance of letting us know if there are personnel changes in your organization very quickly, because you know, they can hold up payment of the grant if they don't have, for example, the correct financial officer. So you want to make sure that all of your information is up to date with us. That's one of the reasons these quarterly check-in calls are so important. But it's also important to just shoot us an email or give us a call if something changes between quarterly check-in. So one last time, any questions from anyone? Well, we want to thank you all for your participation. If anything comes up, by all means, give us a call. We're here to serve. Thanks so much and have a great day.
Thank you, everybody.
Thanks. Thank you.
Bye. Thank you.